Alrighty guys, let's talk about a starting point for assessing, diagnosing and treating shoulder pain. This is something I always found really hard to get a handle of when I was starting out in physiotherapy, because shoulders always seem to present fairly similar. You know, they used to always have just some pain around here, would maybe radiate down the arm, they'd have some limited range of motion. They all kind of seem to respond to similar things, so a bit of manual therapy through the shoulder cuff and some external rotation exercises, maybe a bit of taping to deload it, and that used to get most of the job done. And I probably did this style of shotgun treatment because I didn't really know how to diagnose shoulder pain either. I always found it really difficult to figure out, what was the cause of the pain in this patient, especially when you don't really need to look that far to find plenty of evidence that suggests diagnosing a specific structural cause in shoulder pain is probably not that easy. There's a bunch of stuff around imaging the shoulder that shows, plenty of anatomical changes exist that sound like pathology in people without any pain. Plus, all those special tests that we learn at uni turn out to be not that good at identifying a structural cause in shoulder pain. I remember one day having a patient ask me, well, what's the problem with my shoulder? What's my diagnosis? And I didn't really know, and I remember going off on a big rant about, the tests don't really tell us much, and scan findings don't really tell us much, and really the patient just left thinking I was a nutter and didn't really know what I was talking about. And suffice to say, I didn't see that patient for very long, because it sort of came across as if I didn't know why the patient was sore. I knew why I couldn't identify why they were sore, but it didn't change the fact that I didn't know what was causing their pain or how to be more specific in how that shoulder was presenting to me and to the patient. And that got me thinking about what is the best way to diagnose shoulder pain. If you can't do it via special tests and structure is hard to pinpoint, then how should we actually look at shoulder pain? It's probably not good that we just treat the cuff, tape it up and load the external rotators. There's got to be a better way to be more specific and more defined in how we look at shoulders. And so I came across the work by this guy called Adam Meekins, and I'm probably going to do a terrible job summarizing it, but basically his work looks at classifying shoulder pain into sort of three main categories. And I'll start by saying this is not the everything you need to know in shoulders, but this is a very, very good starting point for the assessment and diagnosis of lots of shoulder pain. G'day guys, I'm Leon the Physio, and let's get stuck in. So this work by Adam Meekins was really good at helping me pinpoint down a classification for shoulder pain that would let me explain to the patient why they were sore, but would also inform my treatment of that shoulder pain. And this was something I found really useful because a lot of the other special tests that we have for the shoulder, they don't always inform treatment. An empty can test doesn't really tell us how we should treat the shoulder. It just tells us if the shoulder's painful or not. So very broadly, what this work says is that you can separate it into these three main categories. And the first one is a weak and painful shoulder. The second one is a stiff and painful shoulder. And then the third one is an unstable and painful shoulder. So then if we're to look into that a little bit deeper, well, what are the features of a weak and painful shoulder? Well, these patients might present with a painful arc when they go to lift. They might have a limited range of motion, but only limited by pain. They won't have a firm structural limit to their range of motion. The pain might present around here, it might refer down the arm. And this is where you'd cluster in all those, impingement syndromes or tendinopathy syndromes or bursitis syndromes. These ones all fall into that weak and painful category. And the other defining feature is that there's weakness in their rotator cuff. Now this doesn't have to be side to side, this is just weakness relative to what the patient is asking their shoulder to do. And this is great because this informs the treatment. We've got two features in this shoulder in that it's weak and it's painful. So what are we going to do to treat this type of problem? Well, we can do a couple of things. So first, let's look at the pain. So we want to do stuff to the shoulder that's going to help relieve the pain. So this is where things like manual therapy, this is where taping can be really useful. This is where we give advice around how to not aggravate the shoulder. This is where medication is potentially useful. And we want to layer in lots and lots of things that we know can be useful for pain. And then the next part is that it's weak. So then we need to layer in different levels of challenge to improve the strength of the shoulder. So initially, you might start with something like isometrics, which also have a great pain relief benefit, but also work on waking up the muscles around the shoulder. And then you can start your process of strengthening in a simple position and then expand that out to more complex situations. The way I like to do it is start in isolation and then build in function. Start with your boring external rotations, maybe they're banded, maybe you do weights sort of inside lying, but add a prescription that will induce strength. So that's that, 6 to 12 reps, 3 to 5 sets, and they need to be fatigued. And then once you're able to build strength over a number of weeks in isolation, then you can integrate more functional movements. So things like bench press, shoulder press, that type of thing. From here, we move on to the stiff and painful shoulders. So the classic presentation of a stiff and painful shoulder is a frozen shoulder. There's a couple of other causes of stiff and painful shoulders that we need to be aware of. So the defining features of a stiff and painful shoulder is that it's, number one, painful, but also is stiff. So it has a less than 50% external rotation range. So it has a less than 50% external rotation range. Now, there's a few causes for this. So the obvious one is a capsulitis, so a frozen shoulder, locking up the shoulder so that it can't move. But the other ones to be aware of are things like an arthritic shoulder. So you don't want to treat an arthritic shoulder the same way as you would treat a frozen shoulder, because you can potentially piss it off and make it a bit worse. The other things to be aware of are things like avascular necrosis. This can cause a stiff and painful shoulder. So with these types of patients, you want to be a bit clearer on the structural cause of the problem. So the way I would look at this is if they've got a less than 50% external range of motion, I would want to know what the joint looks like. So is the joint arthritic and it's the arthritis that's driving this this stiffness? Or is the joint normal and then it by default becomes a capsule that's driving this stiffness? Or is there something really nasty like avascular necrosis that I need to be aware of? So the first thing with these types of patients would be to order a plain x-ray and just get a broad view of what the shoulder looks like to help inform your diagnosis sort of further down the stiff and painful category. Now, if the shoulder comes back with normal shoulder joint anatomy, then you can working on the stiffness and the pain. So again, the stuff to help with pain is the things I listed before. So your manual therapy, taping, maybe some meds, maybe some exercises designed at pain relief and avoiding things that piss it off. Then at the same time, you can work on improving the stiffness. So that's your hardcore manual therapy techniques to try and improve range, but also your exercise prescription should be geared at improving range of motion in the shoulder. Now this can take a really long time to get better, but they're the things that you need to be focused on sort of over that course of time to improve the functioning of that shoulder. And then lastly, you've got your unstable and painful shoulders. Now, these are the ones that have a clear history of dislocation. So it's the young athlete or the person that has clear evidence that they popped their shoulder out and now have an unstable shoulder. The way that you rule this problem in is with your apprehension tests. So the apprehension test, if they're up here laying on their back and they don't like it when you put more external rotation, then they're apprehensive, but that apprehension goes away when you put an AP glide on the shoulder. That's how you rule in your unstable and painful shoulders. Now, if they've had a dislocation, go and get an x-ray as well, just to make sure that they haven't got a fracture going on in that shoulder. And then with these types of patients, look, if they're a young athlete and they play an overhead sport and they don't get the surgery, there's roughly a 90% chance that it'll pop out again. So it's always worth consulting with an orthopedic surgeon with these guys. And then again, focusing on those two problems. So the pain, so you want to do things that help relieve their pain, and then the instability, so doing things to help improve their stability. So that'll be things like building up their cuff strength, but also potentially getting surgery to passively build up the stability in the shoulder. So I hope you found that useful. This is how I started out understanding shoulders a bit clearer. This also really helped with my explanation to patients around what their shoulder problem was, so that I didn't have to say that they had a bursitis or a rotator cuff tear. I could talk them through shoulders fall broadly into these 3 categories that have a number of different causes. It looks like you're in category A, so that means we need to do all of these things. Again, if you like this stuff, give us a like and a subscribe and let me know in the comments. I'm just putting stuff out and seeing what lands. So thanks guys, I'm Leon the Physio, I'll see you later.